Welcome to this presentation on gout. I hope you're having a wonderful day. Gout refers to a disease that occurs in response to the presence of monosodium urate or MSU crystals in joints, bones, and soft tissues. It may result in an acute arthritis, a gout flare, chronic arthritis, which is called chronic gouty arthritis, or tophi, which is tophaceous gout. Hyperuricemia is a necessary predisposing factor for gout, but the majority of people with hypouricemia never develop gout. The reason, they don't know why. Urate or uric acid levels can be elevated because of decreased renal or gastrointestinal excretion, and the renal excretion is the most common, increased production of the uric acid or urate, which is relatively rare, and increased purine intake, which is usually in combination with decreased excretion. The symptoms are swelling, pain, and tenderness in a peripheral joint or bursa. It's most commonly the first metatarsophalangeal joint, which is your big toe, in 56 to 78% of patients. Other joints include the midfoot in 25 to 50% of patients, the ankle in 18 to 60% of patients, upper limb in 13 to 46% of patients, and interphalangeal joints in 6 to 25% of patients. Another symptom could be draining of a chalk-like substance from a subcutaneous nodule under transparent skin, and it often has overlying vascularity, and that indicates the presence of a tophus. And typical locations of tophi are the ear, olecranon bursa, and the finger pulps. First, we're going to talk about acute treatment of gout. And NSAIDs are first-line treatment unless their use is contraindicated. And some contraindications include cardiovascular disease, cerebral vascular disease, chronic kidney disease, history of gastric bypass, history of GI bleeding, inflammatory bowel disease, peptic ulcer disease, and pregnancy. I've listed on this slide some typical NSAIDs that are used and dosages for treatment of acute gout. Out of these, there's no specific NSAID preferred. I would not use Celebrex because there's limited evidence to support the use of it, and there's no consensus on the use of IM or topical NSAIDs. Now, the relative risk for a GI bleed or perforation increases about fourfold in patients who use NSAIDs compared to those who don't use NSAIDs. So the risk factors for an NSAID-associated GI event includes male gender, history of peptic ulcer, especially a bleeding ulcer, dyspepsia, and cardiovascular disease. Age is a significant risk factor, and the increased risk begins at age 60 years and rises thereafter. Risk is also increased with the use of antiplatelets such as aspirin and anticoagulants such as warfarin and corticosteroids or high NSAID doses. In addition to the hypertension and heart failure concerns with all NSAIDs, NSAIDs seem to increase the risk of cardiovascular events, MI, stroke, and death to varying degrees, even in healthy people. About 10% of all cases of drug-induced hepatotoxicity are associated with the use of an NSAID. The risk is about 100 times lower than the incidence of GI, cardiovascular, or renal side effects. The NSAID should be avoided in patients with hypertension, heart failure, diabetic or other chronic kidney disease. NSAIDs can increase the blood pressure, cause fluid retention, and worsen renal function in these patients. Now we're moving on to steroids. They can be given orally. It can be prednisone or prednisolone, 30 to 40 milligrams PO daily for 5 days, or given until flare resolution begins and then taper over 7 to 10 days or longer. They could also be given a methylprednisolone dose pack. One interesting fact is oral prednisolone, 35 milligrams once daily, is equal to naproxen 500 milligrams twice daily in the treatment of acute gout, with no significant difference in pain relief or adverse effects. So short-term steroid use is not typically associated with significant adverse events. Steroids can be given intra-articular or IM. Patients may experience injection site pain with IM or intra-articular steroids. According to prescriber's letter, there's no evidence from clinical trials to support the use of intra-articular injections. Steroids are associated with hyperglycemia, so you need to use caution in patients with diabetes or impaired glucose tolerance. So the next drug is colchicine, and the normal dose is a little bit different. It's 1.2 milligrams for one dose, followed by a single dose of 0.6 milligrams 1 hour later. Now this must be taken at the first sign of gout symptoms. Up to date says 24 hours. My other references said 36 hours. The max dose is 1.6 milligrams per day. And they could take it as 3 0.6 milligram doses if they wanted. The side effects are mainly GI, diarrhea, nausea, vomiting, abdominal pain. There can be some hematologic side effects such as thrombocytopenia, leukopenia, agranulocytosis, muscle pain or weakness, and possible rhabdomyolysis. It is a less desirable treatment option due to its adverse effects and drug interactions. And it can be combined with a steroid or an NSAID in severe attacks. I've actually never used colchicine. I always stick to NSAIDs or steroids. Now we're going to be talking about prevention of gout flare-ups. So we should start uric acid lowering therapy in patients with one or more subcutaneous tophi, radiographic damage from gout, or 2 or more gout flares per year. So the prevention of the recurrent gout flares, tophi, and progressive structural joint damage generally requires a long-term use of drugs that reduce the serum urate concentration, either by enhancing renal excretion of uric acids, which they call a uricosuric agent, or by decreasing urate synthesis, which is caused by xanthine oxidase inhibitors. And it could be a combination of both. Now, it's not necessary to delay starting or to stop existing uric acid lowering therapy during an acute flare. It used to be thought that you had to do that. Now, if you're going to start one of these urate lowering therapies, you should also start anti-inflammatory prophylaxis when starting or just before starting uric acid lowering therapy, and this helps prevent an acute gout flare. So you could give an NSAID, low-dose colchicine, or oral steroid when starting a uric acid lowering med. Now we want to aim for a uric acid level of less than 6, I think it's milligrams per deciliter. Now there's a couple of other drugs that I won't be mentioning, and you might have seen them. There's one called Zurampic, Zurampic, that's the brand name, and another one called Duzalo, which is a brand name, and they were very transient. They are off the market now due to low demand, so we aren't going to be discussing those. Allopurinol is the drug of choice for patients choosing urate lowering therapy. The dosage will vary with the severity of the disease, with a typical initial dose of 100 milligrams orally once per day. The daily dosage should be titrated gradually in 100 milligram increments every 2 to 4 weeks, or at a minimum 1 week, to avoid precipitating a flare-up. Dosage is based on serum uric acid level to control symptoms, and again with a goal of less than 6 milligrams per deciliter. Dosages of more than 300 milligrams per day are given in divided doses after meals. Check adherence to allopurinol before making dose changes. If needed, increase up to 800 milligrams per day in normal renal function or 300 milligrams per day, or even maybe a little higher in kidney disease. Now, allopurinol 300 milligrams usually lowers uric acid by 2 to 3.5 milligrams per deciliter. Now, when a chronic gout med is needed, stick with allopurinol. Typically begin treatment 1 to 2 weeks after flare resolution. Start with allopurinol 100 milligrams a day or 50 milligrams a day if the creatinine clearance is below 60 milliliters per minute. And this is to reduce hypersensitivity risk, which we're going to talk about on the next slide. Check the labs and increase the dose every 2 to 4 weeks. Again, aiming for that uric acid below 6 milligrams per deciliter. Once patients are stable on allopurinol, monitor labs about annually. But don't feel compelled to adjust the dose if patients don't report flares, even if their uric acid level is up. Now, advise patients to stop allopurinol and call you or the clinic for a new rash or itching, especially within 2 months of a dose increase. Now, there are instances of rare hypersensitivity syndrome, and it's less than 1% of patients, and it's usually within 2 months of starting therapy or a dose increase. And these can include the Stevens-Johnson syndrome, toxic epidermal necrolysis, which we've talked about before, and another one called drug reaction with eosinophilia and systemic symptoms, which is also called duress. Now, some people that are prone to this are people that should be tested for this HLA gene before starting allopurinol. And these are patients that are high risk, and these are the Han Chinese, Thai, Korean, and African American patients. Now, Han Chinese is one of 56 ethnic groups in China, but they comprise about 90% of Chinese. Okay, febuxostat, which is Uloric, it's a xanthine oxidase inhibitor, and it inhibits uric acid production. The normal dose is 40 milligrams once daily for 2 weeks and can be increased to 80 milligrams, and it does need renal dosing. Now, due to a higher risk of cardiovascular death, only used in patients who don't respond to allopurinol, who have a severe adverse effects with allopurinol, or in patients for whom allopurinol is not appropriate. Now, this isn't a huge jump in the number of cardiovascular deaths. The post-marketing study found one additional cardiovascular related death for every 91 patients treated with febuxostat instead of allopurinol for about 3 years. So adverse effects are increased liver function tests and or liver failure. So these need to be checked at baseline, after 2 and 4 months of therapy, and then periodically, or if there are any signs of liver failure. Now, probenecid. It's a uricosuric, which increases urinary elimination of uric acid, thereby decreasing uric acid levels. It's a first-line alternative for patients who fail or have contraindications or unable to tolerate allopurinol and febuxostat. Now, avoid monotherapy use in patients with a history of nephrolithiasis because they can, again, there's a risk of developing kidney stones. Avoid in patients known to be overproducers of uric acid because then they can just excrete more and more. And there is a problem with probenecid due to many drug interactions. Key clinical considerations. Well, lifestyle modifications to prevent recurrent gout include reducing the consumption of high fructose soft drinks, fruit juices, fruits, and purine-rich foods, which purine-rich foods are anchovies, sardines, scallops, mussels, bacon, beef, liver, turkey, veal, and venison. So NSAIDs and corticosteroids are equally effective for the treatment of acute gout, with no significant difference in pain relief or adverse effects. Allopurinol is the preferred first-line urate lowering therapy to prevent recurrent gout. It is as effective as febuxostat in preventing gout flare-ups, but febuxostat increases all-cause and cardiovascular mortality, but again, not by much. The allopurinol hypersensitivity assay, or that HLA-B, whatever this test is, should be considered in select patients. So Korean adults with stage 3 or higher chronic kidney disease, and all adults of Han or Thai descent before initiating allopurinol therapy. Thank you for your time and attention. I hope the rest of your day is fabulous.